Good evening, everybody.
Good evening.
Thank you. Thank you. Thank you. Again? In Espanol? Okay. Thank you and thank you. All right, so for those that are in this room tonight and they don't know who I am, my name is Stuart Schlossman, and I too have multiple sclerosis, and that's how all this began years ago. And we did our very first video program in February of 2010, and to this date, we've now held over 195 educational programs. Thank you. Last year, we expanded to 10 states doing programs. This year, when we come to a close, we'll have done programs in 15 states. And easily said is the next 3 are coming up just in March, where we're doing one in Los Angeles, one in Albuquerque, New Mexico, Los Angeles, California, Albuquerque, New Mexico. And then in April, God knows why I'm doing this, but we're doing Denver, Colorado in April. Denver in April. And a person that's speaking at that program, a lot of you may know because you may have read his book at one time or another, Dr. Alan Bowling will be our speaker at that program. So we will be video recording that too, and after it's published, then you'll get to see what he speaks about at our program. Again, for the same reason, you could go to our YouTube channel, and that's easily accessible through our website. You just go to the top of the screen somewhere up there under the information, and it shows you where the YouTube channel is located. Also on the top left is usually our third one down on the left side. It says YouTube in that blue box, and you could just click on that, and it'll take you to our YouTube channel, and you just look up from there whatever you'd like to watch. I mean, there's so much there. So last year was also a very big program a very big year because we did 44 programs. That helped us get over the 195. 44 programs in 52 weeks. Yes, we were all over the place. We also put on a social worker last year. So if you all don't know about it, and if you need a social worker, we have a number, we have an 800 number that you can look at on the website to get to. And it's also in our newsletters when you receive the newsletters, so you can call the social worker. We have a communication tool. That's very helpful, and that's also accessible from the information tab. And that is so that way when you go to your physician's appointment, you can fill this out in advance for everything that's bothering you with your multiple sclerosis. You could find on that two-sided piece of paper. Everything that bothers you, make sure you start filling it out before you go to your physician's appointment, so that way as you're leaving, you don't say, oh my gosh, I forgot to ask you about this. Because this was put together by medical advisors for MS Views and News. And everything to do with multiple sclerosis can be found on this 2-page form. So again, you don't have to have it in advance. You know you're going to have a medical appointment with a neurologist or a nurse practitioner. Just come to our website, click on the tab for Land of MS Communication Tool, and then you can find this, and you could fill it out, circle it, check it, color it, do whatever you want, and use it for your next appointment. Thank you. All right, now I get to the good part. Who do we get to thank for tonight's program? Well, tonight we were funded by Teva Neuroscience. Thank you, Teva Neuroscience. All right, and about tonight's program, because I don't want to sit here and gabble all night to you all, tonight's program is an English-Spanish program. We are not doing it all in English and then all in Spanish. We're going to do it in English and Spanish simultaneously. They're going to go back and forth. So if you don't understand, just pretend like you understand. No, the cameras aren't looking at you anyway, so smile anyway, okay? But give a nod. Yeah, I understand that. Okay, no problem. So the doctor is going to speak first, and he's going to speak about living with MS. Okay, living with multiple sclerosis. What is it about? It's about how you're going to live your life with multiple sclerosis. And after the doctor speaks, we're going to have Dr. Pizarro, many of you know, but he's speaking first. And after the doctor, who's going to speak for 45 minutes, and then we're going to do Q&A, and I'm going to run around with the microphone during Q&A. All right, so make sure I get to you with the mic before you ask a question. But after he's totally finished, we're going to have disability attorney, Social Security disability attorney, Lisa Gonzalez-Getz, and she's going to come up here and speak with you for about a half hour, do Q&A with her, and then we get to say goodnight to you all, okay? So let's get started. Thank you. Welcome.
Good evening, everybody. Welcome to Tampa if you're not from here. My name is Dr. Jose Pizarro-Otero. I'm a neurologist here in the Tampa area. I work with the Neurophysiology Center, where I am the Sleep Center Medical Director and also Multiple Sclerosis Certified Specialist over there. I want to thank Stuart because what he's doing for all of you guys is great. It's inspiring to see how being a patient, he can turn something bad into something good and help so many people. And you all guys benefit from that. This is one of my favorite topics, actually, because it goes beyond just the treatment of MS, which the way I focus my practice is a very multidisciplinary approach. We're used to the approach that you have a doctor that they diagnose you and that's it, and they push medicine just thinking about the MS, when though that's the worst part of your life, what bothers you on a daily basis are the other things that are associated with MS, not directly the disease, okay? Bienvenidos, mi nombre es el doctor José Pizarro, soy un neurólogo aquí en el área de Tampa. Trabajo en el Neurophysiology Center, donde soy el director del laboratorio del sueño y también especialista en esclerosis múltiple. Le doy las gracias a Stuart por lo que hace por todos los pacientes de MS. Es algo inspirador ver cómo un paciente puede convertir algo malo en algo bueno y ayudar a tantas personas y ustedes beneficiarse. Este tema es uno de mis temas preferidos porque es más o menos como yo corro mi práctica. A mí no me gusta solamente diagnosticar el MS y dar medicina, me gusta atender los otros problemas asociados con la enfermedad, que es lo que al fin y al cabo afecta la calidad de vida del paciente de día a día. Disclosures, I have received speaking honoraria from Teva Pharmaceutical Industries. So let's talk about MS symptoms, which you well know, unfortunately know very well about them. Of course, the most common MS symptom is fatigue. By far, more than 80% of patients with MS suffer from fatigue, and one of the most disabling things. Then we have the gait difficulty, numbness, tingling, spasticities, cramps, weakness, vision problems, dizziness and vertigo, bladder problems, sexual problems, bowel problems, pain, cognitive changes, emotional changes, and depression. Following fatigue, I'll say that the other three most common side effects or symptoms, I should say, are the depression, which is over 50% of the patients, pain, which is about half to 3/4 of the patients have it, and of headache is another big one in the next page, which is less common, but depending who do you read, it could be anywhere from 4 to 58% of the patients with MS versus 16% in the general population. Speech problem is less common, but it's another common problem. Swallowing, tremor, seizures, rare, but it's been reported. Breathing problems, itching, and hearing loss. Other problems that are not really the disease but are a complication of having it are recurrent urinary tract infections due to the dysfunction of the bladder, makes you retain urine and promotes that. Also, the inactivity can result in having muscle atrophy, like loss of muscle tone, loss of muscle mass, weakness that is basically from not using those muscles, and is really not related to demyelination or the disease. It's more of a deconditioning. Poor postural alignment and trunk control decreases the bone density, can prone the patients to have fractures, inefficient breathing, etc. And immobility can also lead to pressure sores. Okay. So the strategies are basically, like I said earlier, the days of diagnosing MS and giving a medication and that's it are way gone. Now we have to develop a strategy in which we treat the flare-ups and exacerbations, we deal with all the symptoms management, and then we can do a disease-modifying therapy, but also rehabilitate the patient to improve function and quality of life and give psychosocial support. In Spanish, basically, en español, los días de tratar, diagnosticar y dar una medicina para MS y ya, esos días se acabaron. Hoy en día el enfoque es en la estrategia, en qué hacer para mejorar la calidad de vida del paciente, manejar los síntomas. Los síntomas más comunes de la esclerosis múltiple son el cansancio, la fatiga, en más del 80% de los pacientes. Por mucho es el síntoma más común. Depresión en más de un 50% de los pacientes. Problemas cognitivos, problemas de dolor de cabeza, espasticidad, calambres, dolor, que casi es entre la mitad a 3/4 partes de los pacientes de esclerosis múltiple. Problemas para hablar, problemas para escuchar, problemas de la vejiga, problemas para evacuar. Y hay otros problemas asociados a la inmovilidad, como el poder respirar adecuadamente, como el desarrollar úlceras de presión, como desgaste muscular y atrofia por descondicionamiento, por no usar los músculos, más por eso que por la demielinización como tal. Now, on the disease-modifying therapies, I'm not going to abundantly talk about all of them. I'm just going to mention them through, and later in the Q&A session, if any of you have any questions about any of the medicines, feel free to ask me. So we have the injectables, which we have galatimer acetate, brand name Copaxone, and now the generic equivalent, which is Glatopa. We have the interferons, beta 1A, which is Avonex and Plerity and Ribif, and then we have 1B, which is Betaseron and Extavia. Then we have all the oral medications, pills, which are basically the dimethyl fumarate or Tecfidera. We have fingolimod or Gilenya, and we have teriflunomide or Obagio. We have now the infusion IV therapies, which are the naralucimab, which is a monoclonal antibody, which is Tysabri, and another monoclonal antibody infusion, which is Lemtrada, which is the most recent one. And from the old days, we rarely use it anymore, but we have an old cancer medicine called mitoxantrone or Novantron. This is what we have for now. Next to come soon, there's another monoclonal antibody that is probably going to be launched later this year. It's called acrolizumab. So the approach is to manage the symptoms throughout the disease course. The effective symptoms management requires coordination, requires rehab strategies, medications, and emotional support. Eventually, every medication used to treat MS symptoms is off-label, which is one issue we always have because they were created for something else. And when we try to use them for MS, sometimes if it's an expensive medicine, we encounter problems with insurance approval because we're using it off-label. So fatigue, like I say, that's the most common symptom and is the most common disabling symptom. Along with cognitive dysfunction, that's the most common cause of early departure from workforce. The fatigue is misunderstood by the family members and employers because it is interpreted as laziness or disinterest. It's one of those invisible symptoms that nobody understands because they don't see it, so they don't feel it. And you know what I'm talking about. The fatigue is really multifactorial. There's not just one reason for the fatigue. It can come from, so first we have to identify why. We have to see about the sleep quality, if there's a disrupted sleep, if there's muscle fatigue, or if there is disability-related fatigue, if there's depression, if it's related to the medication, if our lifestyle choices like smoking, sleep deprivation, or is it the nature of the person's work? So we have to develop a comprehensive treatment plan in looking into energy conservation, planning, prioritizing, having mobility aids if you need them, walkers, canes, wheelchairs, and doing whatever you need to do, environmental modifications, so that you can deal with it in a non-medication way. Have a good exercise regimen, either supervised or unsupervised. That's extremely important. That is the natural medicine. And of course, when this is one of my P's, given my specialty, but it's optimize the sleep, even if you have to see a sleep specialist. And later there's a slide I'm going to talk a little bit about that. And eventually, well, there are medications that can help you with fatigue. We have the amantadine, modafinil, and armodafinil, and stimulants like amphetamines and methylphenidate. La fatiga, como dije, es el síntoma más común en sobre el 80% de los pacientes. Igual que los problemas cognitivos y de memoria, es la razón más común por la cual los pacientes dejan la fuerza laboral antes de los que se supone. La fatiga es malentendida o malinterpretada por los familiares y por el patrono, porque lo interpretan como vagancia o falta de interés, cuando es uno de los síntomas invisibles que no vemos pero sentimos, y ustedes bien saben a lo que me refiero. La causa de la fatiga es multifactorial, y lo primero que hay que hacer para abordar la fatiga es ver cuál es la fuente, viendo si es el sueño, si hay una pobre calidad de sueño o cantidad de sueño, si es por los músculos, si es por la depresión, si es por los medicamentos, por estilos de vida o por la naturaleza del trabajo de la persona. El plan básicamente es desarrollar un tratamiento comprensivo en donde haya un plan de conservación de energía, de descanso, conseguir ayudas para movilidad como sillas de rueda, andadores, bastones, hacer los ajustes necesarios en el entorno, planificar, hacer ejercicios, la medicina natural, obtener los mejores resultados de un buen sueño. Y si hay que ver un especialista de sueño, pues ahorita hablaré un poco más de eso. Y hay medicamentos que pueden ayudar a el cansancio, como amantadín, modafinil, armodafinil, y estimulantes como anfetaminas o methylphenidate. Next is temperature intolerance. 70 to 80% of the patients experience heat sensitivity, which by far is the most common, specifically the summer months, or living in Florida, that doesn't help. But interestingly, there's 20% of the patients that actually have cold sensitivity, which is less common. So slight elevations in core body temperature related to environment, pressure, exercise, fever can cause temporarily worsening of MS symptoms, or so-called pseudo-exacerbation. So cooling strategies like air conditioning, scarves, cooling vests, drinking cool liquids, cool showers, ice buckets, whatever, can help maintain core body temperature. Now that I'm talking about this is a good area to maybe, if any of you have a question about what an exacerbation versus a pseudo-exacerbation is. Usually an exacerbation would last over 24 hours and should be in the absence of any fever, infection, urinary symptoms, or being sick, having a pneumonia or cold. While the pseudo-exacerbation usually lasts less than 24 hours, and there's some symptoms related to either sleep deprivation or being sick, having fever, having a cold, as an explanation for that. Intolerancia a la temperatura ocurre entre un 70 al 80% de los pacientes, ocurre un gran número de los pacientes, del 70 al 80% es intolerancia al calor, que es el más común esos meses de verano, viviendo en lugares cálidos como Florida, el sur de Estados Unidos y Puerto Rico. Saben lo que me refiero. Interesante, hay algunos pacientes, la minoría, un 20%, pueden tener intolerancia al frío. Elevaciones en la temperatura basal del cuerpo relacionado al ambiente, al ejercicio o a la fiebre pueden causar síntomas transitorios de esclerosis múltiple, lo que se considera una pseudoexacerbación. Usualmente dura menos de 24 horas, diferente a una exacerbación que usualmente dura más de 24 horas y no está asociado a fiebre, catarro, ni estar enfermo, ni estar deprivado del sueño. El mejor tratamiento para esto son estrategias de enfriamiento como aire acondicionado. Si es intolerante al frío, pues bufandas, chalecos para enfriar, líquidos fríos, duchas frías, que para ayudar a mantener la temperatura basal del cuerpo. Visual symptoms. That could be related due to different things, but most common, you have the optic neuritis, which can happen in some patients with MS, usually characterized by pain in the eye, loss of vision in one or both eyes, color blindness, blurry vision, difficulty seeing bright lights, difficulty seeing low contrast, blind spots, color blindness. Some patients may have nystagmus in which their eyes are moving repetitively, like jerky eye movements from up and down or side to side, and there could be associated dizziness, oscillopsia, nausea, or pure visual acuity with that. Also, another thing called very commonly seen with MS is the intranuclear ophthalmoplegia, or INO. That is a lateral gaze impairment that the affected eye cannot move inward. It just stays lateral, so you cannot look to the center. So the way we treat this is the kind of the way we would treat an exacerbation. We can use corticosteroids, which may resolve the visual symptoms. You can also use precursor of the corticosteroids. You can actually use a hormone called ACTH, which actually is FDA approved for optic neuritis and for MS exacerbations. It basically promotes your own body creation of your own endogenous steroid. And of course, occupational therapy can provide tools and strategies for individuals to help them with visual acuity and the symptoms. Síntomas visuales causados mayormente por tres entidades. Está la neuritis óptica, vista en muchos pacientes con esclerosis múltiple, caracterizado por un dolor en el ojo, uno o ambos ojos, donde hay pérdida visual en uno o dos ojos, puede haber una ceguera transitoria, visión borrosa, puede haber dificultad para distinguir colores, dificultad para poder lidiar con luces brillantes o para poder ver en la oscuridad, puede haber manchas en la vista. Otra entidad es el nistagmo, que es un movimiento repetitivo de los ojos de una manera brusca, donde puede haber mareo, náusea, poca agudeza visual, y la oftalmoplegia intranuclear, en donde es un defecto para mover los ojos de manera lateral, donde el ojo afectado no puede rotar hacia adentro. Estas entidades casi siempre se tratan como se trata una exacerbación con esteroides para mejorar los síntomas visuales, o se puede tratar con un precursor de esteroides como la hormona ACTH, que ayuda a que el cuerpo provea sus propios esteroides y está aprobada por la FDA para neuritis óptica. Y terapia ocupacional es importante para tener una estrategia de cómo mejorar los síntomas y vivir con ellos. Bladder issues is extremely common. More than 75% of patients with MS experience this. Is a major cause of morbidity and embarrassment that leads to social isolation. There's two types of bladder problems. One is the storage dysfunction, the other one is emptying dysfunction. Storage is basically that this bladder is small and stiff. So because it's small and stiff, the capacity of filling up, it's limited. So you have urgency, you need to go quickly, you go very frequently, you can have some urine coming out or incontinence, and you can wake up at night, go pee. So to approach this, the best thing is, one, to have a bladder plan in which you may have scheduled breaks, so you go to the restroom so often, empty the bladder before it gets full, and then there's some medications that can be given, like anticholinergic or anti-muscarinic medications. The emptying dysfunction is because it's all the other way around. It's a big, weak bladder that basically doesn't have enough power to contract. So that makes some urine stay inside the bladder, creating possible complications with urine infections. Again, the same symptoms as the spastic bladder. It's your urgency, frequency, waking up at night, incontinence. Also a bladder plan, schedule restroom breaks, and the same medications like doxybutynin, Vesicare, Ditropan, and some people can also get a implanted bladder stimulator that can help. Disfunción de la vejiga se debe a dos problemas, uno es de almacenaje, el otro es para vaciar la vejiga. El de almacenaje, estamos hablando de una vejiga pequeña, rígida, que tiene dificultad para vaciarse, causando síntomas de urgencia, frecuencia, yendo al baño muchas veces, con prisa, donde puede haber incontinencia y se levanta el paciente de noche para orinar. El tratamiento es tener un buen plan en donde uno vaya al baño de una manera regular y organizada muchas veces para evitar que se sobrellene la vejiga, y medicamentos como anticolinérgicos y antimuscarínicos para ayudar a vaciar la vejiga. El problema para vaciar la vejiga es todo lo contrario, es una vejiga grande, débil muscularmente hablando, que no puede vaciarse, teniendo retención de orina en la vejiga, causando posibles complicaciones como infección urinaria, y los mismos síntomas de urgencia, frecuencia, levantándose de noche a orinar, incontinencia, y se trata con medicamentos parecidos, anticolinérgicos, antimuscarínicos, y se puede tener un estimulador de la vejiga implantado, y igual que el problema de almacenaje, pues tener un buen plan de ir al baño muchas veces de una manera organizada. Bowel issues is experienced by about half of the patients with MS. Commonly, constipation is the most common. Some patients may have loose stools, but it's related because of impactation and not emptying the bowel. Some others, it's least common, but may have bowel incontinence. To manage those symptoms, first, of course, make common sense, is adequate fluid intake, drink enough water, enough fiber, probiotics help a lot, exercise to stimulate motility of the gastrointestinal system, and sometimes in the case of the incontinence, you can use anticholinergic medications like loperamide, the so-called Imodium, and medications like that. Problemas del intestino, mayormente es estreñimiento, es el más común por mucho, en alrededor del 50% de los pacientes pueden tener un poco de excretas sueltas porque están impactados en algunos pacientes, y pocos pacientes pueden tener incontinencia. Para manejar estos síntomas, lo mejor es tomar buena cantidad de líquidos, agua, comer fibra, frutas, probióticos, hacer ejercicio para promover la motilidad intestinal, y medicamentos para la diarrea en el caso de aquellos que la tengan, como Imodium, loperamida, y también importante, se puede usar ablandadores de la excreta o stool softeners. I think I didn't mention stool softeners in English. That's another thing that may help. Spasticity, it's around, half, also 40-60% of patients with MS. It's more common in the legs. You can have cramps associated with that. They could be very painful. And honestly, the best management about this is stretching. And I always stress how important stretching is. It's not just stretching, it's stretching, stretching, stretching. It's at least 3-4 times a day when you wake up, at noon, at night, maybe halfway through the afternoon you want to do it again, because the more you do this, the less cramps you get, the less spasticity you get, and the less stiff you get. And if you really do that all the time, rarely you're going to need anything else. But sometimes some patients need help from medications, and that's when we recommend muscle relaxants. Usually not any muscle relaxant, like not cyclobenzaprine, like Flexeril. No, it's usually centrally acting muscle relaxants like baclofen and tizanidine, which work more in the central nervous system than in the muscles. Sometimes they can use benzodiazepines like clonazepam. I rarely have benefit from those, but it can be used. Gabapentin, cyproheptidine, dantrolene, dopaminergic agonists have been used, but honestly, the best results you get from baclofen or tizanidine. Baclofen, not only by mouth, but it can be given directly in the spinal cord through an intrathecal pump. Some patients can handle those same medications, but instead of orally, in a compounded cream. It's not as good, it's not as effective, but some patients have gotten benefit from those. And sometimes we can use Botox injections, nerve blocks, and surgery to help. Now, some spasticity can be useful. I mean, sometimes we don't want to eliminate all the spasticity, specifically in the upper extremities. I mean, if your hand is spastic like this, and we eliminate that, you actually could use that hook. You know, you can use it to lift up things, or your purse, maybe press a button. If we put Botox, for instance, there, or give you therapy and loosen that up, then you may lose that benefit from that spasticity. So it should be evaluated in a practical way. La espasticidad es experimentada entre un 40 a un 60% de los pacientes. Es más común en las piernas. Lo mejor para la espasticidad es estiramiento, pero estiramiento de una manera organizada, por lo menos 3-4 veces al día. Yo me canso de enfatizar en los pacientes lo importante que es el estiramiento. Mientras más lo hagan y más veces al día, menos rígidos se ponen y menos medicina necesitan. Pero a veces se necesitan medicamentos y ahí pues se utilizan relajadores musculares, principalmente los de acción central, como el baclofen y el tizanidine. Otros relajantes musculares como la ciclobenzaprina o el flexeril son más musculares y no funcionan tanto a nivel central. Otras medicinas como el clonazepam, gabapentin, cyproheptadine, dantrolene y agonistas dopaminérgicos se pueden utilizar, pero casi siempre los mejores que funcionan son el baclofen y el tizanidine. Algunos pacientes pueden recibir el baclofen en una bomba intratecal directamente a la columna vertebral y algunos pacientes utilizan estas medicinas en una crema básicamente hecha, compounded, para ponérsela o aplicarla en las áreas musculares de más dolor. Y pues medicamentos como la inyección del botulismo, el Botox, bloquear nervios y cirugía a veces ayudan. A veces la espasticidad es bueno en algunos momentos utilizarla en favor del paciente, porque si hay un paciente, por ejemplo, con una mano espástica, puede utilizar esa espasticidad para agarrar algo o enganchar algo. Si uno elimina eso, a veces pues pierde funcionalidad. Sexual dysfunction is also very common between 40-80% of men and women with MS. Usual signs or symptoms of sexual dysfunction are reduced libido, behavioral, environmental strategies may help with this. Sensory disturbance, usually some medications like the pain medications can give some decreased sensation, so that affects also, and anorgasmia, or not reaching the climax. Usually primary sexual dysfunction is related to the MS causing direct issues in the sexual organs. Like for instance, in women, it could be dryness, itchiness. So usually with this I recommend like lubricating gels. Sometimes some gels have lubrication and also some local hormones which help maintain the structure of the vagina and help with the pleasure, the sensation, etc. In case of the men, there's erectile dysfunction, and now we have so many medicines for that. But also you have the implants for those that cannot tolerate those medicines. Disfunción sexual ocurre en 40-80% de los hombres y mujeres. Una falta de líbido o deseo, problemas sensoriales, algunas medicinas utilizadas pues hacen que los pacientes no sientan o tengan una sensación reducida o no poder llegar al clímax o anorgasmia. En este caso, los problemas primarios son relacionados directamente cómo el MS puede afectar la esclerosis múltiple a los órganos sexuales. En el caso de las mujeres con resequedad, picor y en ese caso lubricación con gels o cremas, algunas de ellas con o sin esteroides locales, hormonas locales, ayudan a aumentar la sensación, el placer, la lubricación. En el caso de los hombres, la disfunción eréctil, hoy en día hay muchas medicinas para eso y también hay implantes que se pueden utilizar. Secondary dysfunction, sexual dysfunction, is usually the things you get indirectly from having MS that affect your sexual performance, like having fatigue, being tired, having spasticity, or bladder dysfunction. So that's basically managing the symptom that is affecting. Like, for instance, you treat the bladder dysfunction, you give whatever you need to give for the spasticity and cramps. You give something to promote energy, like for the fatigue, the Nuvigil or the Provigil or the stimulant. You can give physical therapy to increase the range of motion and positioning techniques. A little bit about what I was talking earlier, body mapping exercises. Basically, I have some couples do that. There's some sensitive areas in the patient's body that are tender or sensitive, that is affecting that intimacy. Communication and dialogue is extremely important between the couples, and so that they can do a body mapping and let the partner know which are those areas, so that the partner already knows in advance which areas are off limits or what areas to avoid. That's what I refer by body mapping. And then finally, tertiary dysfunctions are the depression, anxiety, attitudes and feelings that affect. So that really is communication, dialogue, education and counseling. Los síntomas secundarios sexuales son más relacionados a los problemas de función sexual indirectos por tener la esclerosis múltiple, como cómo puede afectar en el acto de intimidad, el cansancio, la espasticidad, la disfunción de la vejiga, y en ese caso es tratar esos síntomas para que entonces no interfieran con la intimidad. Cuando se puede hacer un mapa corporal en donde la pareja le digan a su pareja qué áreas del cuerpo son sensitivas o dolorosas, para que la pareja sepa con antelación qué áreas evitar. Finalmente, terapia física para aumentar el grado de movilidad y posicionamiento, para así facilitar el funcionamiento, el performance. Hay medicamentos que se pueden utilizar como antidepresivos, estimulantes, como dije anteriormente, para mejorar los síntomas de cansancio, de depresión que puede afectar la intimidad. Y finalmente, la disfunción terciaria sexual, que es más esos problemas de intimidad relacionados a estar deprimido, a estar triste, ansioso, que ya eso se trata con terapia de pareja, con educación, con psicología, viendo psiquiatra y teniendo apoyo. Cognitive problems, that's very common, and that's one, like I mentioned earlier, along with the fatigue, is one of the most common problems why patients would come out of the workforce earlier. It happens in 65% of patients with MS. It ranges from very mild to very severe. It's really related to the amount of lesions, the location of the lesions, and the degree of brain shrinking or atrophy. Can occur at any time in the disease course, and any disease course can have cognitive dysfunction. Being in an exacerbation is a risk factor for having more cognitive dysfunction. That's why it's important that we treat the exacerbation to reduce the risk of developing cognitive dysfunction. Most common problems are memory, attention, concentration, and information processing. It can occur alone, or it can occur as part of the depression that by itself is going to give you some cognitive dysfunction or memory problems. Here is a teamwork between the neuropsychologists, speech therapists, and occupational therapists, which can perform a comprehensive cognitive evaluation and a rehab plan even though their tools for assessment are different, all of them have the same goal of enhancing the function, the productivity, and independence of the patient. So treatments here are, of course, treating the exacerbations, the disease-modifying therapy to reduce the amount of relapses, memory exercises. You can give ADHD medications to help with the focusing, treating the depression if it's warranted, and keep reminders, lists, logs, diaries, calendars, organization skills. Problemas de memoria cognitivos son bien comunes en 65% de los pacientes con esclerosis múltiple, como dije anteriormente. Junto con el problema del cansancio, es una de las razones por la cual los pacientes dejan la fuerza laboral antes de lo debido. Puede ser desde leve hasta severo, puede correlacionarse con la cantidad de lesiones, la localización de las lesiones y la cantidad de atrofia o daño cerebral que haya por la enfermedad. Puede ocurrir en cualquier momento de la enfermedad, y en cualquier momento de la enfermedad o severidad de la enfermedad puede darse, sea leve o sea severa. Estar en un ataque de MS es un factor de riesgo para tener más falta de memoria, por eso tratar los ataques es importante para reducir la falta de memoria. Los problemas más comunes son, además de la memoria, son inatención, concentración, procesamiento de información, y esto puede ocurrir solo o puede ocurrir junto con depresión. Casi siempre un equipo entre un neuropsicólogo, un terapista de habla, patólogo del habla y terapista ocupacional pueden hacer un plan, una evaluación comprensiva, un plan de rehabilitación, y aunque los mecanismos que cada uno de ellos utilizan para evaluar son diferentes, todos tienen el mismo fin para mejorar la función y la productividad del paciente, igual que promover la independencia del paciente. Tratamientos para medicamentos que modifiquen la enfermedad y bajar la cantidad de ataques es importante. Además, rehabilitación cognitiva como ejercicios de memoria. Se puede dar medicinas para ayudar a enfocar, como medicinas para el síndrome de inatención e hiperactividad. Se trata la depresión si es que es necesario, y herramientas de organización como listas, calendarios, agendas siempre ayudan. Depression is one of the most common symptoms of MS. It's anywhere over 50% of the patients. It can be related to many things, among them the psychosocial stressors, the brain damage that causes the neurological changes, and the immune system changes. Important, MS patients have 7 times higher risk of committing suicide than the general population. Actually, the greatest risk factor for suicide in MS is actually the depression. So it's really under-recognized, under-diagnosed, and under-treated. And that's extremely important. Like I said earlier, it can also affect the memory. So it can happen together with cognitive dysfunction. And so here, of course, the treatment are depression medications, psychotherapy, exercise. La depresión es extremadamente común en la esclerosis múltiple en más de la mitad de los pacientes. Se debe a diferentes factores, entre ellos los problemas psicosociales, el daño cerebral que ocurre con la enfermedad, el daño neurológico, cambios en el sistema inmune, y esto puede llevar al problema más grande, que es el suicidio, que es 7 veces más común en pacientes con esclerosis múltiple que en la población general. El factor de riesgo más grande para suicidio en esclerosis múltiple es la depresión, y el problema desgraciadamente es que la depresión es poco reconocida, poco diagnosticada y poco tratada. Como dije anteriormente, afecta a la memoria también, y la recomendación aquí es psicoterapia, medicinas y ejercicio. PBA, something that you may have seen maybe in the TV, and many times I get asked about that. It's pseudobulbar affect. May happen in 10% of the patients with MS. It's a sudden uncontrollable expression of laughter or crying without any apparent trigger. And there's a medicine called Nuedexta that's the only medicine that have shown is pretty good for that. Afecto pseudovulvar, sale mucho ahora en los medios, me preguntan mucho sobre eso. Ocurre hasta un 10% de los pacientes con esclerosis múltiple. Es episodios repentinos de llorar o reírse descontroladamente sin ninguna explicación que se pueda identificar, y hay una medicina ahora que se llama Nuedexta que puede ayudar con eso. The pain, managing pain happens 3/4 of patients with MS. Mainly the pain in MS, and something I try to explain a lot of people, is central pain, is nerve pain. It's not like other pains that are going to respond to pain, opioid medications. You have the paroxysmal pain, which is intermittent episodes, like trigeminal neuralgia, headache, and you have the continuous pain with dysesthesias, which is like an altered sensation that hurts. Usually we use anticonvulsants like gabapentin, pregabalin, carbamazepine, also known as Neurontin, Lyrica, Tegretol. And you can use old tricyclic antidepressants like amitriptyline or triptyline. Then you can have some muscular pain, musculoskeletal pain, mechanical pain, which is the muscle sores. And there you use anti-inflammatory medications, muscle relaxants, physical therapy. Okay, and you have the spasticity or cramps. I already discussed a little bit how to treat those. El dolor en esclerosis múltiple ocurre en un 75% de los pacientes. Es un dolor neuropático central del nervio que raramente responde a opioides o medicinas narcóticos. Es un dolor que se trata con anticonvulsivos como gabapentin, pregabalin, carbamazepina, o hay otros pacientes, algunos tienen un dolor intermitente que es paroxismal, otros tienen un dolor continuo con disestesias, que son como unas alteraciones en la sensación que duelen. También se pueden tratar con algunos antidepresivos tricíclicos de la vía generación, como amitriptilina, nortriptilina, y también los anticonvulsivos. También se puede tener dolor secundario al MS como dolor musculoesqueletal, que se trata con antiinflamatorios, relajantes musculares, terapia física, y la espasticidad o los calambres que ya mencioné anteriormente. Speech problems happen maybe 40-50% of the patients. Those are more rare. You can have dysarthria, like impaired volume control, poor articulation, poor emphasis, and you can have dysphonia, which is like a low tone of altered voice quality, pitch control, breathiness, hoarseness. It's usually related to the spasticity of the muscles of the face. Usually you treat this with speech therapy. So it's important you identify it soon so that you can consult the speech therapist earlier in the process, not when it's too late. Also, fatigue can affect the person's ability to communicate due to tiredness. Exercises help, also compensatory techniques to improve speech clarity, and in the patients that need it with a low pitch or tone, they can use some amplifying devices to augment the voice. Dysphagia or difficulty swallowing is less common, but although it's less common, it's important to identify it very early because it has a profound effect on the morbidity or mortality, because it's the one that can eventually lead to fatality. It requires prompt attention, because if you identify the patient is having issues with coughing or choking after a meal, you want to take care of that early. The patient can develop aspiration pneumonia or severe complications. The fatigue can also interfere, just like the speech, with the swallowing, and also with the chewing process. So consulting a speech therapy, again, is important earlier in the process. The problem is that it's not identified until it's too late, in part because the patients don't always report it to the doctor, and because the doctors don't always ask the patients. So that's important to be addressed earlier in the process. So it's important in the clinical history, talk to that about your doctor. In the examination, the doctor should check that. There's some studies that can be done, like a barium swallow, to see how are the mechanisms of swallowing. And like speech treatment is therapy, dietary modifications like MASH diet, chewing strategies, and non-oral feeding options if needed. Gait problems are very common: climbing stairs, having balance, stamina, and concentration while walking. And for that, it's important the physical and occupational therapy, specifically focus on gait strengthening. There is a medication, the so-called walking pills, the dalfapiridine or Ampera. Works like in half of the patients and have demonstrated increased walking speed in the patients, and it helps strengthening the nerve signal to coordinate walking. Also treat the pain and the spasticity that is going to affect the walking. Problemas para caminar ocurren comúnmente para subir escaleras, para coordinar el caminar, mantener balance. Es importante la terapia física ocupacional para empoderar el caminar. Además hay medicina como el dalfapiridín, Ampera, que ayuda a la mitad de los pacientes. Aumenta la velocidad de caminar y puede ayudar, como funciona es que ayuda a la señal del nervio que coordina el caminar, y tratar el dolor y la espasticidad es importante. Tremors, also very common, is the rural tremor. It's potentially disabling. There's really not effective treatments, but usually propranolol, primidone, acetazolamide. I usually use alprazolam or Xanax or clonazepam. Those usually work for me a little better. Occupational therapy also helps, and thalamic surgery for tremor really did poor results. Dizziness and vertigo is also very common. There's some vestibular occupational therapy that the patient can get. You can give antihistamines like meclizine or Antivert, scopolamine patch behind the ear, and anti-nausea medicine also helps. And finally, I think is sleep problems. Last but not least, it's very common. Patients can have sleep apnea, either central sleep apnea, where they don't have the signal to breathe because of the MS damage, or obstructive, due to the lack of oxygen flow. Also, the Willis-Ekbom disease or restless leg syndrome, or periodically movement disorder, when it's a movement disorder at night, when the patient is kicking, trashing all night, not having a restless sleep. Also, insomnia and narcolepsy have been reported higher than the normal population in patients with MS. Finally, the end complications that could lead to fatality are a serious infection due to the UTIs, aspiration pneumonia, pulmonary dysfunction, ulcers, untreated depression with the suicide, and osteoporosis leading to fractures, falls, and fatality. So at the end, lifetime changes is extremely important. Live your life with a balanced activity, rest, sleep at least 8 hours per night. Do have a supervised exercise plan. Eat a balanced diet, low fat, high fiber diet. Avoid heat if you're heat sensitive. Drink plenty of fluids, water, at least 1 gallon per day. Maintain your bladder health and avoid constipation. And have your normal preventive medicine screening. Whatever's the expected preventive medicine guidelines for your age group, follow those. Colonoscopy, mammogram, pap smears, etc. And reach out. Talk to other patients. What you're doing here. Get your support network. Go to your support groups. Become an educated consumer. And look for a physician that really cares about all these things and is willing to help you. That's very important. Have a good, wise plans when it comes to choices of employment, financial planning, and health and wellness. The last part I want to talk en español. El problema del temblor, el mejor resultado que a mí me da es con medicamentos que tranquilicen, como el alprazolam. Es bien deshabilitante por la pobre coordinación. También está el problema de complicaciones que llevan a la fatalidad, como el aspirar, infecciones de orina, úlceras de presión. El dormir es importante. Muchos pacientes con apnea del sueño tienen apnea, muchos pacientes con esclerosis múltiples tienen apnea del sueño, sea central o obstructiva. Central es que no respiran por el daño que la esclerosis múltiple hace en el cerebro. Obstructiva es por falta de flujo de oxígeno. Se ha reportado también insomnia, narcolepsia en los pacientes con esclerosis múltiple con una incidencia más alta, y problemas para síndrome de piernas inquietas o Brice-Ekman disease, que es un desorden que no deja al paciente dormir bien por movimiento en la cama. Al fin y al cabo es importante que hagamos cambios en nuestras vidas con una dieta balanceada, saludable, alta en fibra, baja en grasas, hagamos ejercicio, sigamos las recomendaciones de salud para nuestra edad, de medicina preventiva, tomemos mucha agua, por lo menos 1 galón al día, y todo lo que conlleva una vida saludable y sana. Thank you very much. I hope this was helpful.
Thank you, thank you. So how many of you understood the last part of what he just spoke about? Show of hands. 1, 2, 3. Come on, even I understood. No, you didn't understand it? Okay, sorry. Well, at least you understood what he said before that. Okay? So now that you got to hear it in English and Spanish, who has the first question for the doctor? Don't be shy. Okay, finally we got somebody.
I know you said about the speaking, but my question is can you also have problems like with singing where you have trouble, where you start coughing because of spasticity, or is that something different? It's a question I keep forgetting to ask my doctor.
Sure, no, yes. I mean, at the end I have to like speed it up a little bit, but yeah, both with the speech and swallowing. There is a mechanical problem that could be because of the spasticity, the stiffness of the muscles of swallowing, the muscles of the face, and to cope with it, yeah, there's some posture changes because, of course, the way you sit is going to affect that. And that's one of the areas that you're going to work with the therapists, actually, with the speech therapists and with the physical occupational therapists. It's not only techniques on how to chew or how to enunciate or how to move your mouth or how to swallow, but also how to sit. Yeah.
Dr. Pizarro, I just saw on your slides there, on the Tremors slide, you had something beside it said rubral. I don't know what that is. I've never heard that.
Yes, there are different types of tremors, okay? Like you have Parkinsonian tremor, which is like a resting, high amplitude, pill rolling tremor, and then you have essential tremor, which is like a tremor that you get when you hold a cup of coffee, and then it goes away when you don't use your hands. If you hold a fork, it starts happening again. Those are not really that much related to MS, though essential tremor can happen more also in MS, but the common type of tremor in MS is rubral tremor. It's a tremor that comes from the area of the brain that deals with a small motor coordination. So it's more like a shaky, high frequency, low amplitude tremor, usually affecting kind of like essential tremor, but it's not the same. I mean, like it wouldn't respond to primidone, which is the one that usually patient with essential tremor will respond to. I give primidone to a patient with a MS rubral tremor and doesn't respond like with the essential tremor, like it goes away like immediately or very significantly. I've seen with the rubral tremor, what really helps is decreasing the firing of that area of the brain with something like a benzodiazepine, like alprazolam or clonazepam. Also, the normal physiologic tremor we have, all of us shake a little bit, that's our physiologic tremor. So MS patients can have an enhanced physiologic tremor and combined with that rubral tremor, and then being anxious just makes it worse. So that's why those medicines can also help.
I don't remember what I read, but since I was diagnosed, I'm feeling more anxiety at night, especially at night. The other day I was itching all over, and I told my husband, "What is this? I'm itching all over." And he just said, "Just control yourself." And I took a Xanax, which I don't like. I'm anti-medication. I want to do all natural, but it didn't help. So I took the Xanax, and it helped, but did it again. That has to be with the MS?
Yeah, I think there's two factors there. There is the factor of the anxiety associated with having MS, and then the insomnia that is part of that anxiety, and then the itchiness with some patients with MS report, which might be either due to medications. I don't know what disease-modifying therapy you have, but some of them may cause itchiness, and sometimes the nerve damage, can give you some itchiness. But eventually, many patients have the potential to not needing anxiety medications, specifically when it comes to insomnia. Insomnia is just anxiety that is channeled at night, because when everything is quiet, everybody goes to sleep, that's when your anxiety comes out to haunt you. And it's really been there all day. It's there 24/7. Since the day, it's already there. And it gets like a snowball accumulating throughout the day. When you go to that bedroom and you go to that doorstep, all the lights are shut down, everybody's sleeping, that's when it explodes. So the way to manage that, eventually being medication-free, is be taught how to deal with your anxiety. And that is not easy because there are not many people know how to teach that. It's what is called cognitive behavioral therapy. And it's taught by a psychologist or behavioral professional that have been trained how to teach cognitive behavioral therapy, in which they help you how to control impulses, stimulus during the day, so that when night comes, you're already entering the night with a less degree of anxiety. And then how do you, when you go to that bed and you have those intrusive thoughts, ruminating thoughts, how to block them without counting chips or thinking about it. But the more you think, I want to sleep, you're not going to sleep. You're just making it worse. So that's why it's a stepwise program, usually 5 different areas that they work with you to teach you cognitive behavioral therapy, how to do it. They're actually, because there's so shortage nationwide about people knowing how to teach cognitive behavioral therapy for insomnia, you can get it online. There's websites like cbtforinsomnia.com or shot.me that you can pay and you can get it online, because there's not really a lot of people that know how to teach that. Okay?
Any other questions? Great.
I wonder if there's a way to not have to be getting up in the middle of the night. Last night I got up 5 times to make sure I can do what I had to get done. But the problem is, and one other night I don't even get up. How and why is that happening, sir, please?
So like I say, there's two possible problems. One is that your bladder is small and stiff, which is the storage problem. Or the other way is that your bladder is weak and big. That is the emptying issue. So you have to probably see a urologist so that they can identify which is the one that you have. If it is a small bladder that is very stiff, then you probably not drinking water before you go to bed, probably going to urinate before you go to bed, maybe having a medication to help you empty your bladder completely before you go to bed. And if it's the other way around, if it is the big, weak muscle bladder, then also emptying before you go to bed. That's the one that you may want to do a self-catheterization to empty it, whatever's left over. And you may want to go pee before you go to bed, don't drink liquids before you go to bed. Unfortunately, that's kind of, the way to approach it.
Anything else? Anybody else? Okay, then we want to thank Dr. Pizarro for speaking here tonight.